So thank you for coming. My name is Adam Wash. I'm Communications Director for TNA, and our purpose here is to provide the nursing side of the story in the Ebola case, and I will quickly introduce Zolnierek. She's the Executive Director of TNA.
Hi, thank you for coming. To my right is Joyce Batcheller. She is a nursing colleague, a long-standing member of Texas Nurses Association, and was the chief nursing officer for the largest healthcare system in Central Texas for about 19 years. And to my left is Stacey Cropley. She is our nursing practice director here at the Texas Nurses Association. We're happy to hear, in her own words, that she is doing well, the nurse who was infected with Ebola in Dallas. So she's in our thoughts, and we extend our heartfelt wishes for a full and speedy recovery. Nurses deal with infectious disease every day in their line of work. They're fundamentally prepared to care for patients with infectious disease. And we are confident that nurses are able to care for Ebola patients if they're provided with the appropriate organizational support, equipment, access to the CDC guidelines, and take the necessary precautions and use their nursing knowledge to do so. I'd like to make three main points. One is, and I think we've kind of heard initially in the media, it sounded like there was a interest in placing blame somewhere. When something goes wrong in healthcare, it's much more productive to look at what went wrong, how it happened, why it happened, so we can look at that system of care where nurses are interacting with a team of professionals and figure out what went wrong so action can be taken to prevent it from happening again. Secondly, hospitals are obligated to provide the resources and support to nurses so that they can safely provide care for patients. And that includes access to personal protective equipment, up-to-date training, and clear guidance on how the protocols, the CDC protocols, will be implemented in that organization. And then finally, nurses have a responsibility. Our first duty is to our patients. And as licensed professionals, if we believe that we are in a situation where we cannot provide safe care, it is incumbent upon us to raise that concern in our organization in a manner that it can be responded to and resolved. So thank you again for coming, and we'd be happy to entertain questions.
A little bit more about the nurse. You had mentioned that she seems to be doing well. Do you all know her? And any more details on what she was doing for Mr. Duncan?
We don't know her personally, have not had personal contact. We have heard that she has stated that she's doing well. We just got off a conference with the CDC, and they indicated that she continues to be stable.
On the issue of preparedness and resources, do you feel like most hospitals have done enough? We saw over the weekend, particularly in California with the nurses union out there, that they feel like perhaps too much is being asked of nurses, and perhaps too much blame is being placed on nurses when things are not going right.
I think we share their concern about preparedness. Ebola is new to us. It's an infectious disease, which is not new to us, but Ebola itself is new to us. And I think its appearance in the States has caused us to really look at all of our processes, our equipment, our protocols. Are we prepared, and to relook at that? And there's a lot of training going on. With this infection of the nurse, CDC has gone back and relooked at the whole process to identify, may there be something else that we need to be doing. I know, Joyce, if you...
I would just add that many organizations started to look at...
Can you go up to the mic?
Oh, sorry. I would just add that many organizations started to look at all of what they had in place when we initially heard that there was a patient coming over to the Emory system in Atlanta. And a lot of information has been going out through professional organizations, and being able to share that kind of information as a way to be proactive. So I think that people have already been really on top of that, and this, of course, is just going to cause everyone to be even more judicious in terms of going through, and as Cindy said, looking at what their practices are, looking at equipment that's available, et cetera.
We we've had some prominent doctors in the last few days who have said that perhaps we should be taking this limited pool of patients that we've seen in the United States to one of these 4 centers that is designed to handle this sort of thing. Do you all have any position on that?
TNA does not have a position on that. I really think the experts are at the CDC, and I know that is one thing that they are evaluating. However, despite that, as they just said on the call a few minutes ago, all hospitals need to be prepared because you don't know if they're going to receive a potential patient with Ebola. So there has to be some level of preparation through all organizations, and then whether when someone is diagnosed, whether they're treated at a specialty organization, I think the CDC is thinking that through.
What are you telling your nurses? I mean, this is obviously a new age and something we don't have a lot of experience with. Would you run down that, and if you could also repeat, because of the beeps, it was hard to hear you, just your support and your association's support for this nurse?
Our association support, we support, we've tried to verbally support her and tried to support in terms of it's not a blame situation. And, you know, I think there's really been just a groundswell of support and sympathy from not just nurses, but for healthcare providers who understand that, you know, we do face danger. I was talking with someone on Sunday who didn't realize, well, nurses could be, you know, encounter a dangerous situation. We do. Nurses in ER face violence every day. Nurses have high risk of back injuries. Nurses are at risk for infectious disease. We saw it in the 1980s with the AIDS and HIV situation where nurses were contracting it through needle sticks and other such things. So there is very much a level of empathy and support for that nurse. And I
The other thing is just what are you telling nurses? Because this is, like you said, it is new for us. You know, what precautions, I know their hospitals are doing training, but what are you telling your nurses?
I think a couple of things. One is, you know, people are concerned, nurses are concerned because we all care about our own health and well-being. But to be confident in what they do know as educated professionals in terms of infectious disease, that they do come with a knowledge base and a skill level. And then that they have, you know, when you take responsibility, that's empowering. And they're responsible for caring for the patient, so they need to think through, am I able to safely care for this patient? Do I have the protective equipment that I need to read up on what that means? You know, what is being faced, so they can bring those concerns to their organization and work towards getting them resolved. We very much support empowerment among practicing nurses and participating in solutions, and that's really the message that we're sending to our members. And I think Joyce and her organization, that was very much a part of her practice, and what she's been recognized for is that process of really involving nurses in those solutions.
There was a conference last week in Dallas, and it was a magnet conference. There were about 8,000 nurses in attendance, and there was a lot of proactive education that went out to people that were planning to attend. And actually there was recognition for both Susan Grant at Emory and Dr. Cole Edmondson at Dallas Presbyterian and their staff in terms of the great work that they're doing. And the staff were very proud because there were many from Dallas Presbyterian that were in the attendance, and they were very proud of the work that they've been doing. And I think we have to have confidence that staff are going to use their professional judgment, and if they're not comfortable with something, they're going to speak to their leadership about that, which I think is what we always try to have as our norm, so that people can feel comfortable being able to say, maybe I need more information on this, can you please explain this again, or let's go over and really look at what we have in stock in terms of equipment, et cetera.
Do you feel overall training is adequate across the state?
You know, as Cindy said earlier, there is always a lot of training that goes on that starts in the nursing schools in terms of how they need to take care of patients, because you're at high risk for a lot of different diseases if you don't. So I think that there is a lot of training. I think that this is just heightening it even more so. And I think that as Cindy said, there was a call just a few minutes ago with CDC, and they're committing to sending a team of experts into any hospital that may end up having a patient that's diagnosed with Ebola, and they've got people on the ground now in Dallas. And so I think that, you know, we should feel confident that we've got people really being very, very, you know, critical, looking at every single step of the process to make sure that things are done correctly.
You talk about nurses having the right equipment to care for Ebola patients. have y'all discussed what other equipment might be necessary or needed?
Other equipment, I think that most hospitals have the kind of gowns and masks and things that they need. I think it's a matter of making sure that people are really, really aware of what they need to do in the case of having a patient with Ebola. And that includes, I think what they've done in Dallas is having someone that watches as you put the gown and the gloves and the masks on, as well as how you take it off, so that there isn't any chance of contamination. Because, you know, when you're in the setting and you're taking care of the patient, that's what you're focused on, is the patient. So someone else watching to make sure that if there's a splash of some sort or whatever, that someone can point that out to you very quickly. Because that's what they do. They focus on the patient.
And in fact, the CDC just announced that kind of 3 key things that need to be emphasized. And they said the most important thing was to have a site supervisor, specialist in infection disease, who is really critically watching what is going on and can catch opportunities where there may be a slip in process or procedure or an opportunity to improve things. That is in Africa, that has been the single most effective strategy.
It's been hard in all of this for us to get the viewpoint of nurses, obviously, because they don't want to ruffle feathers with their employers. Since you all speak for them, could you kind of give us an indication as to what the level of concern or trepidation is among your members and what kind of things they're saying to you?
Sure. Our nurses are concerned, and they should be. This is something that, of course, in the media has been portrayed as something that really needs a closer look in terms of process and procedure. But our nurses have the basic knowledge, skills, and education that they're prepared with in their academic preparation to manage infectious diseases. With the support of their facilities, with the support of mentors and associations like ours, our nurses are prepared to take care of these patients adequately.
Could someone kind of clear up a little bit of the public perception here? I think that there was this initial report that this patient who had come from Liberia had mentioned that he had been in Africa. Somewhere in the system that broke down. It wasn't translated on to the caregivers who arrived later, but you know, we were talking about this earlier. We heard the nurse got the information, the doctor didn't get the information, so it's almost as though people are left to fill in the blanks and think, well, the nurse must have messed up here. Then we heard from the CDC that there had been a breach in protocol, which again, I think a lot of people took as being the nurse's fault. It seemed like they really walked that back yesterday, but could you kind of give the public kind of clear the air on that?
We can't really speak to the specifics of what happened at Texas Health Presbyterian.
But you've been hearing from your members, obviously.
But we've been hearing from other nurses in the community and some of their concerns. And the overriding theme here is that when there is a question about process or procedure, our nurses are empowered to ask those questions of their supervisors. They should be looking for those answers and relying on information provided by the CDC. Those are the best resources for nurses out there to get the important clinical information that they need to care for patients presenting with symptoms of Ebola.
Are they feeling, though, like a lot of the blame is falling on nurses here? We've heard that, you know, especially on social media, that seems to be sort of the way to proceed.
I think there's been some, and I think, you know, it's kind of the translation. And again, my understanding, nurse entered information into the electronic medical record. So that is a way of communicating the information. So if a physician doesn't access that information, the nurse may have believed it was communicated. I think, though, what happened with that and the terminology break in protocol, that's kind of assumption. If you think you're protected and you're not, you assume there was a breach in protocol. But I think the general public leaps to assume that means someone did something wrong, and it may not. It may be, and what we've learned a lot in healthcare is when things go wrong, rarely is it individual by themselves. There's a process. Hospitals are very complicated organizations, and there's a process, and there are many variables involved. So that's why it's really not helpful to look for, okay, who made a mistake that we can punish. It's really the tougher issue is to really analyze that situation and say, where are all the opportunities where something could have gone wrong, and how do we put something in place to prevent that from happening? And I think, like with this breach in protocol, the CDC is now trying to analyze and reviewing everything that happened to try to identify what went wrong so they can prevent it from happening again. It doesn't mean the nurse did something wrong, but obviously something went wrong.
Considering that usually when problems do occur, they are systemic, have you been hearing from members who work at Texas Health Presbyterian who are concerned just because one worker there did come down with it? Are you hearing from them?
What I've heard, we do have a member on our board who works at THR. And what I've heard from her is just how impressed and proud she has been of the nurses and how they've rallied support around the nurses who cared for Mr. Duncan when he was being cared for, and for the nurse. That they really have a very positive practice environment and nursing culture there. And I've heard they've felt very positive and very supported. I don't know,
How
Joyce,
hard
I
is
know
the
you've
job?
had contact.
Yeah, I would just echo that that's exactly what I got to hear and see last week is when the nurses were there, and I would personally say thank you for the great work that you're all doing. They had a lot of pride in the fact that they were on top of this and really helping to support one another. I can just say that when you say that there was a breach, that sounds like the nurse intentionally thought, gee, maybe I'll just mess this up, and that is not true. I mean, people are putting themselves out there to take care of anyone any day of the week that potentially there could be some sort of harm, and it's never done intentionally. But I think what you hear Cindy describing and all is that we're trying to figure out, so since this person did things the way they were supposed to be doing, what perhaps didn't we see or catch, and what do we need to learn from it? And the only way you do that is if you get people really comfortable being transparent. And so when you hear those words, sometimes that can be kind of a negative connotation, and it makes people feel unvalued. And so I think that we're trying to make sure people don't feel that way. The staff there are working very hard.
You mentioned a while ago, one, that Ebola is new to you. You also mentioned that one of the questions you're asking yourself is, are we prepared? What are, this being new to you, and what are nurses, both in your organization and elsewhere, doing to prepare themselves? Are there training classes underway, or hospitals conducting workshops, that sort of thing? What else being done to
That's
prepare
what,
for this disease?
well, we're hearing from our members in hospitals that they are getting training. They're getting lots of practice sessions, which also is highly recommended. It's one thing to be trained, whatever that might look like, but to actually get to practice donning and removing equipment, and so you become more skilled at it. The other thing that we are doing, and Stacey may want to speak to this, is when we first heard about the potential with health information systems, and there may be parts of the system that may not communicate or people may not access, that we have a health information technology team with the Texas Organization of Nurse Executives, and they are putting together a webinar that I think we're offering in the next week or two, and it's going to be offered nationally, to help nurses understand where there may be some risks in their process of communicating, and how to make sure that information does get communicated.
So the material that we're presenting will include some updates regarding Ebola and where we're at in terms of managing Ebola and our preparation for Ebola. And then we'll also be looking into health information technology platforms and how we have different systems within that platform that capture nursing documentation and physician documentation, how those communicate, and how the collaborative care process takes place using that electronic health record, and also using face-to-face handoff reporting so that our healthcare team is informed when they're dealing with patients that have Ebola.
Can you all quantify just how hard of a job this is for these nurses right now who cared for Mr. Duncan, obviously, and who are now caring for the nurse who came down with Ebola? I mean, they're suiting up in what look like moon suits to the rest of us and going about some very difficult procedures at times and messy procedures. How hard is what they're doing right now, the stress level?
I would think, I'm not in their shoes, but I can only imagine that it's very difficult, because not only, I think nurses have a difficult job to begin with, but there's that extra level of vigilance, conscientiousness to everything they're doing. And Mr. Duncan was in critical condition, and he was having very advanced level procedures done. So the level application of all that nursing knowledge, but then just that extra vigilance and awareness is mentally exhausting as well as physically exhausting.
Because you're thinking of your own well-being too, obviously.
Sure.
Yes.
Good.
And trying to balance, I think it's very difficult and probably stressful for the nurse's family as well. Although nurses don't share that information when they go home, but certainly the family can tell that, it's a stressful period for that nurses in that environment. Just even when they are supported, which is so wonderful about THR and hearing how the nurses were really caring for each other. I heard that the nurses, because they had to take showers after each shift in the facility, they had to take a shower, that the other nurses were buying them high-end bath products. So there was that kind of caretaking, which is really wonderful to see.
Is that shower taken at Presbyterian as well as other hospitals that are in this situation?
Well, my understanding at Presbyterian, those nurses took a shower immediately after taking care of the patient.
Can you elaborate more on more better procedures that the CDC might be developing these days after the latest events? Give us more details and examples of what could be a better procedure.
I'm trying to remember the three things they. The first one was that supervisor,
Right.
someone
Yeah,
to
that was
specifically watch and track everything going
Mention
on.
3 points.
The second recommendation that they made was in regards to donning and removing PPE, having the appropriate training for putting on that personal protective equipment, making sure that employees understand how to put that on effectively. And then the third item was specifically relating to minimizing the number of healthcare
Yes.
workers that would come into contact with the patient. And so implementing those three measures, and those are just three among a set of recommendations that the CDC has made in order to improve care processes for these patients.
If I get in contact with any bodily fluids, is there any disinfection that can lower the possibility of a transmission of the virus?
I did see on the site, I believe it was on the CDC site, that, but I hate to speak too authoritatively about it, but that there was a disinfectant spray that was used, I think in Africa. Now, I don't know if that's been used in the country here, but if there was, someone was exposed, it was a disinfectant spray that was
give
used.
you a few chances more not to get in contact with the virus.
Right.
There are also 2 nurses from Emory that have already come here to Texas that are working with the team at Presbyterian in Dallas. And so I think that, I would also share with you that there was really quick telephone calls that went from the Emory system to the THR system as soon as they heard they had a patient, because I'm friends with both of those chief nurses, and they had already connected up. So I think that spirit that you hear about people really pulling together and wanting to really help support one another is very, very much alive in the nursing community. People are wanting to make sure that we can take care of patients very adequately, as well as take care of each other as caregivers.
And was that phone call sort of a tricks of the trade? Here's some of the things that we should impart to
Sure.
you from what we've learned.
Yeah, I did a virtual, hey, Susan Grant, do you know Cole Edmondson? You guys should really talk. And their email back to me was already on that. And so I thought, that's super, because I think that, professionally, people do tend to reach out. They want to help. They care.
Can I ask you a quick question on number 2 when you're talking about donning and removing that PPE equipment? In some videos we've seen complete moon gear where no skin is exposed, but quite a bit of, especially Texas hospitals, seem to just wear the goggles and the regular mask with a lot of skin exposed, neck and face, and then as they're taking it off, they're taking off the dirty glove with their hand and so forth. Is there any type of protocol or something that nurses should watch out for here in Texas on their gear?
The blood and body fluids precautions really kind of emerged out of the HIV/AIDS era, because we learned that's how it was spread. And before that, we never wore gloves, and unless you're doing a sterile procedure.
Never did.
And masks were even rare. So the principle is, you want to protect yourself from any kind of body fluid. So if you're going to be touching or being exposed to those fluids, you need to protect that skin. So you would wear gloves if you're going to be touching someone. You might wear a gown if you think there's a splash, or a shield if there might be a splash in the face. But if you don't expect a splash in the face, some procedures you don't, you wouldn't necessarily wear that. Like you might start an IV using just gloves. But if you're going to intubate someone, you probably want a shield because there may be fluids. So there was judgment involved. I think that, the spacesuits that you're seeing are kind of to do the maximum protection. Again, because this virus is so virulent, and when someone is critically ill, they're probably more apt to have body fluids that the individual may be exposed to that's caring for them. So I think that's why you're seeing the full.
Do you know what kind of work Nurse FAAN was doing on patient Duncan's team? Did she ever intubate or administer dialysis?
She probably would not have intubated, but she may have assisted with it. But I don't know. I don't know. If he was intubated, certainly there are a whole number of fluids involved in that. Dialysis, we don't know what type of dialysis he was receiving. But if she was caring for him, I'm sure there was, lots of opportunity for exposure.
Would you err on the side of caution, though? Would you tell
Yes.
nurses in your organization, maybe you should wear the shield all the time? Or maybe, do you tell them anything that they should do over and above what their hospital protocol may be?
If it's a confirmed Ebola case, yes, you probably want to. Would you need to wear all of that for every patient that you see? No.
So say that again. In a confirmed Ebola case, what would you advise the TNA members to do?
Well, and I'm not the CDC expert, but I would think you'd want the maximum coverage. If it's a confirmed Ebola patient, and those are the patients that are going to be in isolation rooms and you're going to have special procedures for. But for patients coming that present from the ER that you don't know, you're going to follow those basic principles. And we have an ER nurse here who can maybe be able to respond afterwards to some of those questions that you're going to use those basic principles and protect yourself from exposure. But if it's a confirmed Ebola case, I would think you'd want the maximum protection.
You mentioned a while ago about the number of contacts, with an Ebola patient. I may be mistaken, but I think I heard that as many as 75 people might have had contact with Mr. Duncan. Is there an optimum number? What would y'all recommend in trying to limit this to?
Oh, in terms of number of
contacts.
it's kind of number of caregivers.
Yeah, number of people, right, who would have contact, just to keep the Ebola from spreading.
You would probably have a cadre of nurses, day shift, night shift, enough to carry through the week where they would still be able to have their adequate time off and rest. And you'd probably look at your other, identify what respiratory therapist is going to be assigned to that case per shift. And you'd probably, identify staff by their staff type and who's going to be responsible for that case. So in that way you can limit, rather than someone different every day. Joyce, do you have?
I was going to say that I think what it shows, though, is that you need a lot of different kinds of caregivers for a patient that's very ill in a critical care unit, particularly. So I think what they're trying to do is get a number, though, of the various disciplines that are needed that they can really concentrate that sort of training and expertise in. But I think the contacts weren't just the staff. It was also if they had family and others that they were in contact with, that they're working on that.
Joyce, real quick question. You have friends who worked at Emory University. Mm-hmm. Are they recommending or asking for that the spray decontamination be put into effect?
I don't know the answer to that question. I have not asked them that specifically.
And those showers are at the hospital. They're not going home and taking a shower for their shower, right?
Back to the communication that y'all been having. I mean, are there a lot of, is there a lot of kind of an upsurge in email traffic and phone calls among nurses? I mean, just kind of sharing information, that sort of thing. Has there been
The professional nursing organizations have been putting information out, and very, very quickly, I might add. And so the American Nursing Association, the American Organization of Nurse Executives, you have the CDC putting information out. So there's a lot of information that has been very intentionally crafted and sent out to the staff as a whole. And so I think that that's the formal part. What I was sharing with you is the informal networking that goes on very, very quickly amongst the nursing professionals. We're just used to picking up the phone and talking to one another and trying to help each other. And so you see that kind of sharing that happens without anyone having to ask you at all.
If there are no more questions, if they're available, you can have one-on-ones with them. Thank you.
Thank you very much.
Thank you.